Good day and welcome everyone. Thank you so much for joining this Connors Center conversation focused on telemedicine for women. This event is hosted by the Mary Horrigan Connors Center for Women's Health and Gender Biology at Brigham and Women's Hospital, Harvard Medical School. My name's Renee Piazza, and I'm a facilitator with Collective Next. I'm joined by Dr. Haydeen Jaffe, the Executive Director of the Center, and Paula A. Johnson, Professor in Women's Health at Harvard Medical School. Before I turn it over to Dr. Jaffe for some opening comments and introductions to our first panelists, I do have a few logistics. But first, we really want to hear from you. We really want this to be a conversation, so we're going to actually put a question up on the screen. And we'd love to hear where you are calling in from today or where you are joining us from today. So thank you, Jeff. So you'll see that question on the screen and you can just go ahead and go to menti.com. You can do this on a mobile device or you can do this in another tab on your browser, and that's menti.com. So you go to menti.com and you're going to type in a code. Oh, and we have the URL is right there in the chat. So if you click on the chat button at the bottom of your screen, the chat window will open. Great, I see some coming in. And there's a code there, and I'll read the code as well. It's 7932710. So go ahead and open up the app and you can watch this fun. I see a lot of Boston, Arkansas, awesome. Cape Cod, Chicago. Welcome everyone, it's so great. It's so great. Thank you for spending this time with us on a Friday. It's really terrific to have you here. Give it another minute or two. So we'll use this again in just a few minutes. So now you've had a chance to use it, it'll be easy peasy. All right, excellent. Vermont, some locals, California. Does it say Albania? Portland, Oregon, awesome. All right, well, terrific, thanks for participating. We have a really exciting program for you. We're going to actually bring that program up now so you can take a look at where we're going to go today. So while that's being pulled up, oh, thank you. There it is, lovely. We have a variety of experts from Brigham Health, Always Health Partners, Ms. Medicine, and Bayer. So this session is being recorded. We will provide the recording to all registered attendees. You'll also notice that there's some what we call graphic facilitation or scribing that will be taking place throughout the session at the bottom of your screen. And we'll provide that artwork to you as well as just an artifact of this event. We very much hope that you will be part of the conversation today, and we invite you to do that in a couple of ways. One, which you've already been doing right there in the chat. So feel free to make comments in there, say hello. And if you have questions as you are listening to the panel discussions, please put those into the Q&A. The Q&A can also be found at the bottom of your screen, and we'll be mining that section for those questions and monitoring it throughout the event. And then at the end of each panel, we have some time for 1, 2, maybe 3 questions. So please put your questions in there. We'd love to hear from you. We really do want this to be a conversation, and it's just great to know there's folks out there when you're doing these kinds of events. So thank you so much. Okay, over to Dr. Jaffe, Executive Director of the Center, for some opening comments and some introductions to our first panelists.
Thank you, Renee. So welcome, everybody. It's such a pleasure to reconvene. This is our second virtual program through a webinar format. and we have been delighted to stimulate and engage conversation across the country and across the world in really important areas that relate to the health of women. This is the major focus of our center, the Connors Center for Women's Health and Gender Biology, based at Brigham and Women's Hospital at Harvard Medical School. And we have, as part of our programming, educational programming and research activities that stimulate critical discussion about critical topics that are so near and dear to all of our hearts. Today, we put together a really excellent program related to telemedicine. This is something that's real in our life. This is something that has become, hugely available and hugely important for care in the COVID crisis, but there's also a history of telemedicine that precedes this rapid access and utilization. We will learn from experts in the field who play different roles as clinicians, from the health insurance, from industry, from people running healthcare, telemedicine, healthcare organizations, and from the pharmaceutical companies. So we are really thrilled to present such a broad perspective on such a critical issue. And because of our particular focus, we're going to address issues that are specific to women, which is not limited to maternal and reproductive health. It's across the lifespan. And we're going to try and keep a lens on that throughout all we talk about. So I'm grateful for you to join us and participate in the conversation. We want this to be a dialogue, and a question and answer parts will be included in all the panels. I also want to thank our partners and sponsors. We have tremendous partnership at the Brigham with our Women's Health Advisory Board, also the Women's Health Access Matters and Access Circles organization, the Massachusetts Life Science Center, and through this webinar, we are partnering with Miss Medicine and Always Healthcare. I also want to recognize the sponsors for our virtual educational programs, particularly Bayer, that's been our primary partner and will continue to do so, as well as other sponsorship from Mass Life Science, Sojournex, Candy Pharmaceuticals, Philips, and Fidelity Charitable. We couldn't do this work without this broader engagement. So thank you all for being here. And I think it's time for us to turn this to the first panel, which I will be moderating. This first panel is the Clinician Perspective. And I'm delighted to have an opportunity to introduce three clinicians at the Brigham who are affiliated with the Connors Center, who provide clinical care, outpatient and inpatient clinical care, and are also researchers and academics, leading experts in the field, in their own fields. I will introduce them and have an opportunity to engage in a virtual panelist conversation with them. So let me start by thanking the three of you for being here. Dr. Pace, thank you for serving as our representing primary care, and also in your role as in the Connors Center and leading our global women's health programming and our policy and advocacy program. Dr. Carusi from the Obstetrics and Gynecology Department, thank you for joining us. And I know you have a subspecialty related to high-risk pregnancies that we'll be talking about as well. And Dr. Mittal from the Department of Psychiatry, with your expertise in leading the Division of Women's Mental Health, partnering with the Connors Center and leading efforts related to telehealth well before there was this crisis that really needed it, but having a specific focus on the care of women in pregnancy. So thank you all for joining us. I think Renee has some ways I'll turn it to Renee to get us started, and then I'll take it from there and let you introduce yourselves in a minute.
Thank you, Dr. Jaffe. Okay, so we asked for conversation, so here's another opportunity. As you can see, we have some amazing perspectives on this panel, and we're gonna have a great conversation. But we thought as a catalyst for that we would ask you as patients to put your patient hat on, because most of us at this point have experienced telemedicine as a patient as well. So we're gonna bring up another question onto the screen here and ask you to, again, go to menti.com And we'll put that link again into the chat. And we're looking for 3 adjectives that describe your experience with telemedicine as a patient. What's that been like? And the code, I'll read it off. I know that it's also in the chat. It is 6122538. So go ahead and there we go. I see them coming in. A lot of convenient, easy, fast. Wow, it's moving fast. This is moving fast. Comfortable, excellent, adequate, awkward, cared for. So I see some in the chat as well. Time saving, concierge, doctor. I have not experienced it. Connected, collaborative, intimidating, private. So a lot of different perspectives. Thank you so much for contributing. And we're going to start here and just I'm going to let Dr. Jaffe kick off our first panel. And thank you very much. And we're going to ask to hear from you throughout the day. So thank you.
Thank you, Renee. So what I wanted to do in opening this panel conversation was give each of you an opportunity to briefly tell me and the audience a little bit about your practice, focusing specifically on the ways in which you have utilized telemedicine so that we can get a feel for your experience, how much of your practice involves telemedicine and how much of it is at the present time, because some of us have gone back to a mixture. So let me have Dr. Pace, if you can start. I'm going to have you as our primary care doctor start this.
Sure. Thank you, Haydeen. So my main clinical role is providing primary care internal medicine at a large academic practice at the Brigham. And then I also work in a specialized breast clinic where I care mostly for women who are at higher risk of developing breast cancer and work with them on prevention and enhanced screening. Prior to the COVID pandemic, I myself provided essentially no telemedicine. I, of course, communicated with my patients electronically often through our patient portal, and then I often communicated with them on the phone in between visits, but I didn't conduct formal visits on the phone or on video myself, though we provided that in a sort of just circumscribed set of situations that I wasn't involved in. And then when COVID hit, our clinic closed to in-person visits. So we transitioned immediately to providing 100% virtual care for our patients for a couple of months. So it was a dramatic change. And we transitioned from doing nearly 100% via phone to probably about 75, between 50 and 75% via video. And now I see half of my visits are in person and then half of my visits are virtual. So I'm kind of 50-50 now.
Thank you. That's super helpful. Dr. Carusi, if you could explain your situation.
Sure. So I see patients in 2 separated practices. So my gynecology and my obstetrics are physically separated in the hospital. The gynecology is a general gynecology practice. And as with Dr. Pace's practice, it went completely virtual during the peak of the pandemic. And we were bringing in patients for, actually a lot of discussion about what was acute and severe enough to constitute an in-person visit. And that was a lot of interesting discussion. But really for high acuity, we would see patients and that was about it. We have continued to do telehealth. We never I don't think our hospital did telehealth formally before that, but we have continued it. And with some schedules blending telehealth and regular visits, and some of us separate our telehealth on a separate schedule. It's also a heavy teaching practice. We supervise residents, so that was a whole new element of how do you supervise a resident while they're conducting telehealth, but we've incorporated that into our schedules now. And then I'm in an obstetric practice that is largely high risk. I see a mix of high risk and regular risk patients. We had to keep going with that, and we had to see patients in person. So there were just strict limits on how many patients we could bring into the office at a time. So it was quite a lot of work for a group of high risk obstetricians to have to choose which patients and which visits would be in person and what we could safely do from home. And I think we learned tremendously from that and feel much more comfortable with it, and have continued to do telehealth, both for our practice and for our patients who want it.
Thank you. We're going to come back to a lot of these themes you're already bringing up, but let me ask Dr. Mattel if you can introduce your practice and a little bit about your work before and during the COVID crisis.
So thank you. I would say that, you know, the majority of my direct face-to-face clinical work with patients shifted with COVID. But even prior to the pandemic, I was doing about half of my consultative work, clinical and consultative work, in a variety of ways, but primarily over the phone through consultation with providers directly through a psychiatric access program called MCPAP for Moms. And MCPAP for Moms is essentially structured such that providers can call into this service, which is a statewide service, and then we're able to provide consultation provider to provider, and then occasionally provider to patient. And that service has continued through the pandemic, and we've shifted somewhat where the provider to patient interactions are all virtual via video visit when primarily. But the other half of my practice, which had been face-to-face patient care in psychiatry, as with my colleagues, has all shifted from face-to-face in-person visits to virtual care. And similarly, we started off largely on the phone with some capacity and uptake for video visits, and that's really shifted over time. Psychiatry is a little bit of an outlier here, though, because so much of our work has actually sustained as virtual care. We really have had a very, very small proportion return to in-person care. And it's been sort of an interesting thing because we are busier than ever. And even in the height of the pandemic, when many other ambulatory services were pared down quite a bit, psychiatry has remained very high volume, if not even higher than prior to the pandemic. And we can talk about some of the drivers of that as well. But, you know, so now I'm fully virtual, and all of our patient care pretty much is video or telephone. And then also our consultation work has persisted.
So thank you. So, you know, important themes here. So firstly, the three of you take care of women. I think Lydia takes care of some men, but you've said primarily women. So we're going to be focusing on the female patient. And what I want to get some of your thoughts about is what are the, you know, what's specific to women here? You know, what is it? There's so many of these issues that are relevant for men and women. But what is it that's specific to women, both in some of the challenges and benefits that's shifting to telemedicine? So I'm going to sort of mix this up a little bit and ask you, Dr. Carusi, to start us off. I know obviously you have male partners involved, but just what is it about women that makes this unique or not?
Well, obviously, the obstetric part is very unique, and it really makes you stop for a second and think philosophically how much of obstetrics is the pregnant woman and how much is a couple. Because with the pandemic, we stopped having visitors come to ambulatory visits, which had a big impact on that dynamic. So I think for the pregnant woman, she still needed care. They were nervous about coming into a hospital, especially during pregnancy, but wanted their prenatal care. And they were learning at the same time as us, like how to manage in-person versus at-home visits. I think, and it's probably not completely unique to women, but it's largely women, is the childcare piece, and the fact that, you know, both obstetrics and gynecology, we often had patients coming with small children in tow, or older children in tow, and that's always a bit of a challenge for them, and trying to sometimes have very personal and adult discussions with their children sitting there, and they want to send them out of the room. And I think it's a little bit easier when they can be in their home environment and their kids can be safely in another room. Sometimes we see them managing their children in their home, but I think they feel more comfortable when they can do it at home and not have to drive in. So I think that's a huge piece of it. You know, it's a little bit harder for me to compare the primary care part between women and men since I only see women, but you know, we have women who are, you know, managing difficult transitions in their lives that can't just be put on hold. You know, women who are, you know, going through new pregnancies or pregnancy issues or menopausal issues. You can't just say, come back next year. You know, those are things, you know, you might be able to put off a screening test until next year, but for patients who are struggling with symptoms, trying to manage that when their practice is shut down can be difficult.
Maybe that's a good forward to Dr. Pace's comments, if you can talk a little bit about that. So from a primary care standpoint, thinking about screening, preventative measures, what you've seen, what you've observed, and the sort of concerns you have about that.
Yeah, I mean, I think there are, well, there are very practical considerations that make some of primary care and delivery of primary care virtually different for women and men, especially women of reproductive age. A lot of the cancer screenings, for example, cervical cancer screening, which as of now requires a pap smear, and breast cancer screening, which requires mammograms, both of those require in-person visits. So there is a lot of care, and important care, that we need to deliver in person. And so that's been, navigating that has actually been incredibly stressful because, for example, our routine screening mammography essentially shut down at the peak of the pandemic in March and April, and our at the Brigham, our breast radiology facility has done an extraordinary job working through the backlog, but we certainly nationally have seen, since they opened, so they reopened in May and June, and we certainly have seen nationally, but certainly in our patients as well, delayed breast cancer diagnoses, for example, and also a lot of concern about increasing disparities in breast cancer diagnoses and more late stage diagnoses in patients who felt less comfortable returning to in-person care or weren't able to return to in-person care. So I think there are unique challenges in navigating how to deliver timely and high quality preventive care for women. Of course, that exists for men too, with other critical services. Colorectal cancer screening, of course, is one. And I think there are certainly opportunities for figuring out how to do this well. For me, there's always some frustration with seeing a woman for her sort of routine health visit virtually and then having to schedule her separately with someone else for her pap smear. Luckily that doesn't require 2 in-person visits for her, so the inconvenience isn't too terrible, but it definitely decreases the comprehensiveness of the care that I provide if I have to see her virtually.
I want to bring in Dr. Mittal here, because one of the things you talked about was the clinician to clinician interaction. You know, people have multiple clinicians in their care, among their care team, and one of the strengths of our system is our ability to communicate through our electronic medical record portal, which our patients participate in as well, of course. I wanted to see if Dr. Mittal, you can kind of walk us through a little bit about how you see telemedicine maybe having some growth opportunities for the patient, the clinician to clinician collaboration. So Dr. Pace is talking about that it's complicated because the person has to go back and forth. Are there other, do you agree with that? Or are there other ways that you think that this is maybe an advantage now that we're virtual?
Well, I think it is complicated, and I think it depends a lot on the needs of the patient. And as you were asking the question, I was thinking a bit about some of my patients who I see in our Bridge Clinic, which is a low barrier substance use disorder treatment program that in which are the people that we're seeing, and that's the only place where I see a combination of women and men. And the needs related to some of the challenges that they're facing, so the complex, like psychosocial complexity in their lives, housing instability, food instability, um, managing comorbid or concurrent mental health and substance use needs really necessitates a multidisciplinary approach. And there are ways in which that approach has been facilitated by the rapidity and the ease with which we now are able to communicate virtually. And also, it's hindered. And so in some ways, one of the things that we would be able to do in our clinic would be to have a number of people come at the same time. And sort of when the patient was in one place, we could have a recovery coach come, a care transition specialist, sometimes a social worker, as well as the prescribing provider. Now that we're not able to do that, there's this coordination that has to happen to ensure all of this multidisciplinary care. And that's become complicated. On the other hand, especially in the height of the pandemic, when we weren't able to get written consent, we were sort of given some permission to be able to have some more communication, and we were able to communicate with outside agencies more easily, and sometimes in some ways knit together sometimes communication in a way that we hadn't been able to before. And when other providers are also more comfortable with virtual communication, we could get on a video conference and talk about care in a way that was made much more easy than had been previously. And so there are these sort of two sides of this. And then also, with all of us being kind of virtual at this point, we also have to sort of understand that our patients are not always as savvy with the system. Sometimes we've all grown more comfortable, and so we've been able to do more in our visits than we had been before, especially from a mental health treatment and engagement perspective. And so I think that's been the sort of another piece of it that's come through.
Yeah.
But our patients also have less control over their environments.
Right. Yeah, I wanted to bring that back to Dr. Carusi because she mentioned that as well. So, part of it is our comfort as clinicians, and part of it is our patients, of course. And navigating that decision-making about maintaining a remote appointment versus when people should come in, if you can kind of talk us through that, because you brought that up at the beginning, and this might apply for postpartum or pregnancy care. Maybe if you can break that down, how you navigate that.
Yeah, it really varies so much. I would say we definitely have patients who are thrilled to be able to be virtual, and sometimes that's because they live far away and we just save them a lot of time and driving in traffic. And sometimes especially during the pandemic, because they just feel safer at home and more comfortable there. We had to present it. Our pregnant patients, I think, were very nervous because they would look forward to coming in to the hospital and either seeing their baby on an ultrasound screen or listening to the baby's heartbeat or getting some reassurance that the pregnancy was healthy. And so it was a whole new problem solving job for us to know, for us and our patients, that we could feel reassured that we had a healthy fetus when you can't look at or listen to the fetus virtually. So, we had to do some work to reassure our patients that way. And I had some who went out and bought home Doppler monitors so that because they just needed to listen to their own baby, but, not feasible for every patient to do that. So there was a lot of education that had to happen. I definitely, we had some patients where we presented to them that we can't do every visit in person, and they were doing virtual visits, but then expressed later that they weren't comfortable with that, and were afraid to mention it because they thought they weren't allowed to be uncomfortable with that. I think some because they needed that in-person reassurance, and some, we learned, and I'm sure in every field, we learned that some people aren't comfortable at home for many different reasons and needed to get out of their home environment in order to come in and see their provider. And I learned a lot more about my patients from this issue coming up. And so I think it's a deeper issue. And I think as we continue to use telehealth beyond in a pandemic when it's necessary, I think that there kind of a lot of considerations to explore there, but I think it's going to be very good for some patients and not good for others, and finding kind of that balance for who it's going to work for.
Yeah, yeah. Now you've all sort of brought up one of this theme, which is that it really does vary. And one of the variations that we perceive in our male and female patients, but focusing here on the female patients, are some serious equity issues. And I want to see if Dr. Pace, if you can sort of expand on that, you know, age-related, resource-related, space-related, you know, where people are taking appointments, these kinds of things. Can you comment on some of that?
I did just want to follow up on the one thing about sort of the individualized approach, which I think is so clear in the adjectives that people shared, you know, so, although actually it seemed like the most of them were positive, which is consistent with what we know about patient satisfaction. There are definitely concerns, and people mentioned cold and impersonal. I loved the adjective glitchy, which that might have been my favorite. So I think the pandemic has not, because the alternative has been, for some of the pandemic, the alternative was no care. So I think that, or no sort of preventive primary basic care. We of course did have urgent care services, but I think a lot of it depends on what the alternative is, and making sure that patients have alternatives that suit their clinical needs, their preferences, their comfort with technology, kind of suit the way that they want to receive care. And I think that we clearly need a lot of flexible options going forward, and how we deliver care needs to be reflective of that. In terms of equity, yeah, I think there are a lot of challenges and a lot of ways that we need to target resources and efforts to maximize access for patients who have the least access to telemedicine. It's certainly harder for me to use telemedicine for my patients who don't speak English. We use an interpreter, but I think using an interpreter is wonderful, but it always introduces a layer between you and the patient. And I think when you're doing the visit on the phone, as is often the case, or via video, having that extra layer, I think, feels more removed, and it often can introduce communication barriers. In terms of interacting on our patient portal, it is available in Spanish, but I think in a slightly more limited way. And so our non-English speaking patients certainly use the portal much less. So I think that there's a lot of the convenience and ease of access that is less available to non-English speaking patients, certainly patients with limited Wi-Fi, limited bandwidth, limited cell phone minutes. There's tons of barriers. Yeah,
I mean, it's a long list. And so, as you all have identified, we need to be very thoughtful and intentional going forward about how we utilize it, because it's not a panacea. And it certainly has a lot of positive attributes, but it has challenges, because there's some things that can't be done in person. We don't want to underdiagnose, underscreen, and also under-reassure people, because there's some things we can't reassure people on in the same way without doing an examination and getting other parameters, diagnostics. So it's very challenging, and it clearly applies to women at all stages in terms of their lives, and across the reproduction specifically. I mean, the obstetric and neonatal services didn't stop during the peak of our pandemic here in Massachusetts, and because those babies weren't waiting, and now we are concerned, of course, that people who didn't come in for certain diagnostic care might have, more challenging issues ahead. So Renee is here to help us sort of bring in some of the questions. And I know we won't always have time to address them all, but Renee, if you can help us with a few of them before we continue the conversation with the next panel.
Thank you, Dr. Jaffe. We do have a few questions coming in. I just want to remind attendees to please post your questions. I see them coming into the chat to the panelists. If you would put them in the Q&A, that would be best, but we're monitoring both. But we actually have time for one question. And this is a tender question. It's for women living with abusive partners. Using telemedicine can be extremely challenging, especially when it comes at sharing health issues related to the violence that they are victim of. How are you handling this in your practice?
Yeah, let me ask Dr. Mattal if you can comment on that about the really vulnerable woman in her own, vulnerable in her own home, not safe in her own home.
So we have come across this, especially in the context of our consultation work. So when we are doing consultations with women for whom we don't have a prior relationship, and one of the things that we've sort of implemented in that context is really offering a very clear and explicit level setting at the beginning to say that they have the control of the content, and so they're able to say what they can and cannot say if they're able to. And then we also have been distributing, when we set up appointments for women, a set of guidelines so that we can create keywords or we can create hand signals to say, like, if there's a topic that's not able to be communicated, or if we're not able to speak freely in that moment. And then this is a reason actually for some in-person care in the context of psychiatry. So we've had patients say that they're not able to conduct virtual visits in the context of a controlling relationship, or lack of privacy, or the content of their concerns not being safe to talk about. And so we've actually made that a criteria for in-person care.
Thank you. And I wish we had more time to speak with all three of you. You have so much wisdom to share and experience. And it's really terrific to see the conversation amongst you, because, there are lessons learned from each field and discipline. So I think it's time that we need to transition to the next panel. And it's really my pleasure to, after thanking the three of you, to really introduce Dr. Pace as our moderator for the second panel. She has really partnered with me in putting together this whole program, and I'm really grateful to her. And I want to turn it to her to facilitate the discussion for the next set of panelists.
Thank you, Haydeen. It's such a pleasure to get to moderate this next group of panelists who do incredibly interesting and exciting work, and I know we'll have a lot of thoughts to share about implementation of telemedicine at the health system and organizational and payer level. So we have three panelists. The first is Dr. Adam LaCursey, who is the Executive Director for Virtual Care at Brigham Health and leads the hospital system's telemedicine team and programming. He's also a Medical Director for Virtual Care for the Mass General Brigham Health System and the Brigham and Women's Physicians Organization. He's an Assistant Professor of Medicine at Harvard Medical School and also a primary care internal medicine doctor. Our next panelist is Dr. Farah Shafi, who is the Medical Director of the Massachusetts-based health plan Always Health Partners. As Medical Director, she works with health plan activities, including utilization management, appeals review, and care management, including targeted initiatives within maternal and child health. She also collaborates closely with the Mass General Brigham Population Health Team on clinical coverage and medical policy decisions for the MGB employee self-funded account that's administered by Always Health Partners. And she is also a practicing OBGYN. And then lastly, Dr. Lisa Larkin. She is a women's health internist, menopause, sexual medicine, and breast cancer risk assessment and survivorship expert. She's a physician and consumer educator who's been practicing in both academics and private practice for over 30 years. She is the founder and CEO of Ms. Medicine, which is a national healthcare organization committed to advancing evidence-based women's gender-specific primary healthcare through an innovative membership practice model and a consumer and physician education platform that's called Ms. Med Ed. So thank you all for being here. I wanted to start off just to get a sense from each of you about how telemedicine was part of your work before the COVID crisis, if it was, and how you've seen telemedicine practice and policies evolve in your organization since the start of COVID. Adam, would you mind getting us started with sharing your experience?
Sure, yeah. Happy to be here. So, before COVID, I'll just say a little bit about, virtual care in my practice, and then maybe the Brigham and Mass General Brigham writ large. But the story before COVID was that the telemedicine, telehealth, or as we say, virtual care now, was kind of a set of small pilots. It was pretty bespoke. It was, kind of a handful of providers who offered either phone or video-based outpatient care to their patients. I was one of the providers at the Brigham doing it, and we did this for years. Actually, I'm not sure sort of everyone was aware that the Brigham offered telemedicine. I did maybe 3 or 4 visits a week, Lydia, which made me one of the highest volume providers at the Brigham. And things have really changed. Starting back in March. If I kept up that volume, I'd probably be the lowest volume provider at this time. So we went from, I'll just say briefly, at the Brigham, about 3,000 or 4,000 visits a year, and now we do that in about a day. As many of the panelists have spoken to already, this was years of adoption, years of development that happened within like a month or two, and it was, in some ways exciting to see these programs grow. But as has already been, discussed a bit, there are also a lot of issues that came up when lots of providers had to do this, as you said, in your practice, from 0 to 100% overnight, and learn a bunch of new technology and figure out, what they were going to be able to offer, virtually to patients without having the, in-person alternative or, a blended model that now, as many folks have spoken to, we've sort of settled in, where most providers are doing, a mix of in-person care and virtual, and that's an interesting sort of position that we've landed in as well. So, anyways, I'll stop there. But it's been a kind of dizzying growth period for many of these programs.
Dr. Shafee.
Yeah, so definitely we've seen what Adam was talking about in our claims volume. So pre-pandemic, we saw some claims related to telehealth, but after the pandemic started, absolutely saw increases to the tune of around 1,000% in terms of the numbers of claims that have come in related to telehealth. And a lot of these measures were put in place from regulatory guidance, both at the state level for us in Massachusetts, as well as at the federal level, in terms of expanding telehealth and expanding the rules around coverage and reimbursement for telehealth. And so this was really put into place because of the need to protect patients and have them be able to offer an alternative to in-person care and keep them safe. So the experience that's been talked about before is just seeing a complete expansion. And then with that comes looking at the claims volume, also looking at how we can best serve our provider community to make sure they can serve their patients' needs.
Thank you. I have to say that the pivot that both of you and your respective groups had to make essentially overnight is pretty mind-boggling to me and pretty amazing. And I have never seen anything like it in my life, certainly. So I do think that you should both feel incredibly proud of that. It was pretty amazing. Dr. Larkin.
All right, so thank you for having me participate in this. I'm really happy to be here. So I have two really different perspectives about telehealth because I sit in two separate arenas, one as a clinician with a practice, and in my efforts to provide evidence-based women's healthcare, as you've already mentioned, there are many things where I feel very strongly that in-person care was really required. But as with everyone else, COVID really forced this very rapid adoption of telemedicine into practice. And I learned as a clinician that there were more things that I could do through telemedicine that I had been reluctant to do. The other side of my life is as a founder of a small women's health startup, and really watching the startup space and what was happening in the femtech space and the growth of telemedicine in the women's health space, and seeing the diversity of things going on. And it's fascinating to watch how quickly telemedicine in all kinds of different settings have been adopted in the startup space. And the growth is so rapid and so extensive that from the lens where I sit, I have a little bit of concerns. You know, there's so much good that has come out of telemedicine in many areas of women's health where we know there's such unmet medical needs and where there are difficulty reaching many patients. But the flip side is, do we really have enough data about what is well suited to telemedicine? What settings are really appropriate? Are we sure we're providing equivalent care? Are we sure we're not going to result in delayed diagnosis in some settings? It's grown so rapidly that has been accelerated because of the pandemic. I have a little bit of worry that we need to have a little bit of caution as we have this rapid adoption in some arenas.
Yeah, thank you for sharing that. We should definitely dive more deeply into that and talk more about some of the ways that you think we can address some of those issues. I would love to kind of follow up on that idea about women's health and telemedicine and sort of, and how policies and practices are thinking about women's health differently. We heard it from the clinician perspective, how our care for women has been impacted, but how are you all incorporating those considerations into policies or at the organizational level? Adam, are there ways that you're thinking about that at Brigham Health or MGB?
Well, yeah, I guess I'd say a couple of things. So one is that, you know, as you heard from Dr. Carusi and OB-GYN and I think Dr. Mittal as well, the percent virtual that makes sense or is appropriate in any given specialty is going to vary a lot. And so we've tried to kind of create systems and you know, targets and approaches that allow for, you know, one specialty that really wants to be in person. You know, I'm not able to, do the kinds of exams and you know, point of care testing that I need to do to safely see patients and maybe female patients in addition. So, you know, I want my, virtual percentage to be 5%. You know, to be able to offer that alongside a department like psychiatry, to use Dr. Mittal's example, where, you know, almost all of ambulatory care right now is happening virtually. And that's probably, you know, not the number where that department will stay, but you know, if you sort of take a one-size-fits-all approach with a 5% department and a 100% virtual department, there's going to be all kinds of issues with that. So we've tried to be, you know, flexible. I think the other thing I would say is that as we've gone from sort of the early days of the spring, where there was a lot of technical advice, but very little sort of appropriateness advice, and, you know, thinking about which patient populations, you know, make the most sense for different kinds of tools, and, you know, sort of what providers want in their toolbox. We've you know, really come up with much more targeted you know, guidance to help different kinds of specialists, you know, meet the specific needs of their populations. So that's been a big part of moving from sort of 70% virtual, where the Brigham was at the height of the spring surge, to, you know, about 30% virtual, which has been a pretty stable number the past couple of months. And, you know, I think to many of us, that feels like the new normal now during the public health emergency and maybe even beyond.
Thank you. So some themes that I pull from that are just the need for your organization to be really flexible and responsive and dynamic, and sort of tailor your approach to different departments and divisions and clinics. I also, it sounds like there's also a big need for provider training and retraining, and because we all adapt to this and figure out what works and kind of change our practices.
And I'd say one other thing, Lydia, that you brought up in your practice. So there are a lot of kind of one-off, I would say, you know, workarounds or approaches that providers have come up with to figure out how to offer a blend of virtual and in-person care. You gave the example of, you know, a preventive health visit that then has a follow-up pap smear, for instance. And, you know, what we'd like is to have, you know, kind of to proceduralize that and have, you know, standards, and to figure out where it makes sense to have, you know, 2 visits instead of, you know, 1 visit. We also, at the sort of other side of that equation, want to keep an eye on overall utilization and make sure that this isn't just, adding telemedicine to routine care, as Farah from an insurance company can speak more to as well, but that it's actually replacing some of the things that we were doing before. But that takes a lot of support and guidance, and what you were describing your practice, Lydia. We're trying to spread those things across departments so that people are learning from one another.
Faria, how has the sort of women's health and gender piece come up for you, if it has?
It hasn't really. It's because a lot of this is regulated in our state and in other states as well as at the national level, that there really isn't a disparity in the sense of coverage or reimbursement for women's health issues. So that hasn't come up just yet. I think certainly the point related to utilization is an important one, because what we just don't know at this present time is, have we driven up utilization and the total cost of care without really seeing an improvement in quality? And that is really something that is on our minds as well as other health plans across the country.
Yeah, thank you. Lisa, that I think I would love to hear your thoughts about, you mentioned concerns about this proliferation of telehealth / telemedicine models. And I heard you express some concerns about quality. What are your thoughts about how to address some of those concerns? What kind of levers we can use to address quality issues?
Right, well, I do have some concerns, and it's really, data is what we need. I mean, I think everyone is trying to understand quality and also without driving up costs, and determine which patients are appropriately suited with which conditions for telehealth in which circumstances. But what has developed is a whole spectrum of telehealth offerings in the startup space, and companies that are growing very, very quickly with a whole diverse offering. And so many of these companies, there are companies out there that offer telemedicine for primary care, right? So having a 25-year-old son, he loved the telemedicine platform for primary care. It's inexpensive. He loved the doctor that he was chatting with on email, felt very comfortable with this. And he's a healthy 25-year-old, right? So that may be totally appropriate. I mean, we just don't really know. But is that same platform going to work for an 85-year-old with multiple complex medical issues on many, many medications, who also has technology barriers, right? So we just don't know. The other setting where I've seen the growth is in really what's basically e-commerce for prescriptions, where there are companies now where it's, what's considered telemedicine is really just a questionnaire and a bot, and then a prescription being sent to the patient. And again, is that the same? That's not the same as the telemedicine that I think we're all talking about performing with existing patients, but consumers don't really understand the difference between that type of telemedicine and what else is going on. And so again, I really believe that all of us need more data about, appropriate telemedicine, and we need some guardrails around things to make sure that we are really still providing quality evidence-based care in the right setting and not driving up costs by duplicating services and all the other things that were mentioned.
Farah, what is a payer's role in kind of setting those guardrails? And is that something you all are actively talking about?
Absolutely talking about that, and to kind of tail on to, onto Lisa's comment about some of the app-based devices that are out there. I think right now, some of the regulatory guidance that we have is related to replacement of in-person care with virtual visits, either video visits or telephonic visits. All of these app-based platforms are more in this realm of digital health, which we had pre-pandemic been trying to understand their role in replacing in-person care. So these are certainly the conversations that we're having. I think the payer's role needs to be multifactorial. We obviously have a fiduciary responsibility of protecting the healthcare costs and wanting to make sure that we're not driving up the utilization and that we're monitoring the quality. And I think that data is going to be forthcoming. We just don't have it yet. In terms of women's health, I just think making sure that whatever decisions we make after the state of emergency, after the pandemic, whatever decisions insurance companies make, we need to be mindful of the fact that we are not creating inequities with respect to women's health with our decisions, and respect to inequities for all populations. So that's just something that we are keeping track of at our company, I'm sure nationwide.
Yeah, that's so helpful to hear. And Lisa, I think it kind of goes back to your point about data. We need to collect the data to understand outcomes, to both of your points, to understand what patient outcomes are. And then we need to disaggregate that data to look at how outcomes are different across different populations as well. Adam, do you have anything to add about what your organization is doing in terms of quality, how you're looking at this?
Yeah, so I guess I'd say a couple of things. One, just to level set, as a primary care provider who now sees patients in person about half the time, and patients virtually the other half the time, as you said before, Lydia. It's not like there is a wealth of informative quality metrics that I'm seeing as a clinician for my in-person care, and that we as a system have for outpatient providers. So I just want to be, I think, realistic that the level of quality metrics in outpatient care to begin with is not great. We get feedback on how many A1Cs we check, or how often we're checking blood pressure. So it's not that high of a bar. But to Farah's point, we are, trying to catch up to at least that level of where sort of office-based quality metrics exist. And, some of the direct-to-consumer companies out there that Lisa mentioned, the main metric that had happened from, companies like American Well, or sort of these, we sort of call them telesniffles companies, was, is there too much antibiotic prescribing going on? So some, antibiotic stewardship metrics, but that was kind of it for a while. I'd say within our system, we're tracking all kinds of short-term, I would say, metrics like who's using the visits, is it being, are different populations using more video or phone? Are we introducing, some of the inequities that have already been brought up around language, race, gender, other kinds of demographic groups. What else? Longer term, we just had a conversation recently that there likely does need to be a quality slate dedicated for telemedicine or virtual care, and to make sure that maybe some of the things that aren't directly related to the sort of the technology around the visit, Lydia, the kind of glitchiness that we want to not happen for these visits, but some of the indirect things like our follow-up items not happening as consistently after a virtual visit. There was just a study recently about fewer blood pressure checks and lipid checks for primary care patients. So that's where I'm getting more interested, is making sure that the right things are happening before and after the visit. And the visit itself, if we provide the right technology and make sure that it's as accessible as possible, it's really only lacking the in-person physical exam, which is crucial for some visits and not crucial at all to to many other visits.
Adam, I know that Mass General Brigham is taking some really important steps to address issues of equity, and really specifically focused on patients' use of and access to our patient portal, for example, which is kind of our gateway to our virtual care. Could you, if you feel ready to talk about that, could you talk about that, or more abstractly, what you think health systems should be doing?
Yeah, so I think if there's a single, sort of united system goal around telemedicine right now, it's to make sure that it's offered equitably. The number of interventions, I would say, Lydia, is pretty long. I'll try to just go through a couple of them very briefly. So one, it's to make sure that just access to the portal is as universal as possible, and to make the entry points much less, much more frictionless than they are right now. So not having to remember as many security questions or download something. You mentioned, I think earlier, the language barrier. So it is available in 2 languages, Spanish and English. We're trying to, add a number of other languages to the portal soon, but that's sort of the initial barrier. Patients do need certain pieces of equipment and access to high quality internet. And so if you don't have those things, that's a problem, and you're going to be limited to a phone call, or have sort of gaps in your care as you're waiting for an in-person visit. So we are trying to do things like actually loaning or permanently giving patients devices so they can use them at home that are internet enabled. And also doing things like making sure that the telephone doesn't go away, like just the plain old, audio only telephone, working with, payers like Always and FARA to make sure that telephone-based care continues, because that, may be a lifeline for patients who only have access to the telephone. The last thing I'll say just briefly is, also you brought up before, Lydia, is the need for interpreter integration and access to the visit. So right now, the easiest way to bring in an interpreter to a virtual visit, as I think you said, is using the telephone and then punching in or patching in a remote interpreter, and much harder to do that by video, much harder to do it I would say in general over telemedicine than in person, because it just sort of heightens the sort of the barriers that are existing, and you worry then that patients who don't speak English as their primary language are just going to be less often seen virtually or less often seen in general. So there's a lot of efforts right now to make interpreter access as smooth as possible, and maybe even better than the in-person access to interpreters that we have. So those are just a few things, and FARA and Lisa may have other items that they're seeing from their perspectives, but it's a sort of number one issue right now.
I think the interpreter issue probably comes up with respect to the telephonic visits. That would make it a lot easier, because I've had a number of visits where I've been able to convey what I needed to convey over the phone, and that certainly would be easier than doing that over a video visit platform. And so that would be advocating for better coverage in terms of telephonic.
Yeah.
The present state right now is that we cover telephonic as well as the video visits. As far as what's going to happen in the future is a little bit unclear, but
it sounds like equity is really coming into your discussions for Always as well.
absolutely.
Lisa, anything you'd want to add about equity and how it's coming into either your clinical practice or your company?
No, everything that's been said is correct. I think this is really a fundamental thing that needs to be addressed as this continues to grow nationally, and the solutions I'm hearing from everyone is great.
Thank you. Renee, I see you.
I'm here. We've been getting a lot of questions from the audience. This has been a really great discussion. So I thought we had a little bit of time that I would just share one of them, if that would be okay.
Of course.
Okay, so this one, what do you all expect regarding insurance policies? There appears to be some pushback now regarding telehealth, especially regarding proposals to reimburse and cover at lower rates than in-office visits.
Farah, this is all you.
Yeah, I think it is all me. I think that it remains to be seen. I know that there is pushback, or there's active discussion nationwide amongst health plans about what the role or what the reimbursement structure is going to be for telehealth. It's very interesting to me to hear from the clinicians on the initial panel and from Adam and Lisa, just that some of this, there seems to be a balance between in-person visits and telemedicine visits. And so this is really ripe for use in value-based models, where the provider can decide how to decide which is the best method to deliver the care, what is the most convenient, what makes the best sense for the patient, but also meeting this need for monitoring the financial responsibilities of the health plan.
Farah, would you mind defining what you mean by a value-based model?
Yeah, so traditionally, we have a great healthcare system. We have a very expensive healthcare system. And so really having this fee-for-service model where somebody sees a patient for a visit and then gets reimbursed, you can see this point of driving up utilization. We've driven up the cost of healthcare, and have we really improved on the quality? So when we're speaking, value-based care can be defined in many different ways, but one of the, I think, looking at novel contracting mechanisms, looking at telemedicine to see whether or not this would be a lower cost of care, and utilizing that in certain situations, and then needing to deliver in-person care, like procedural type care, physical exams, immunizations, in person. So that's kind of what I mean.
Yeah, and then bringing the two together in a way that doesn't increase utilization or increase costs, but actually reduces cost and improving outcomes.
And also that patients would like that a little bit better. I mean, I think that the convenience factor comes up, and I think it is very convenient. We're seeing that on our end. We just need to really monitor whether what we're doing is quality care and also not really increasing expenses of our healthcare system.
I'd love to jump in.
Sorry, no, Lisa, go, please.
So if you don't mind, I'd love to give just another perspective, which is telehealth and what I'm seeing in the startup space as well, and with many of these companies. These are all outside of insurance. These are all cash, televisits, and when in my community, for example, and across the US, where there are people whose insurance plans now continue to have very, very high deductibles, right? They are looking, so these are consumers now who don't want to go to the doctor and have an expensive either telehealth or insurance-driven claim, when they can use telehealth very inexpensively to get prescriptions sent directly to them completely outside of insurance. And although you all are doing amazing work in kind of the data collection in insurance-based systems where you're getting claims, and so you can actually see what's happening. Where I see that this is the wild, wild west is in telehealth and platforms and things that are going on that are completely outside of insurance, and we really don't have any data about that because we don't have insurance claims, and we really have absolutely no quality metrics on this at all. Because, and Adam, I 100% agree with you that the bar isn't all that high in in-person visits about quality as well. I get that for sure. I agree with you. But there's no data being collected on a national scale in these outside of insurance arenas where care is really being provided.
Very interesting. Definitely a new frontier.
And they seem to be targeting a captive audience who didn't have these needs met.
Yeah.
Well, I would just add that, you know, I think unfortunately we're going to be needing to socially distance ourselves for, you know, maybe years. Yeah. And, you know, I think during that period, it would be irresponsible for an insurance company to significantly decrease payments for the, you know, primary way in which large numbers of, you know, members are accessing care. I'd also say that when this is all said and done, I think there are going to be millions of patients that just now expect this, and in the same way that remote work and, you know, virtual work is going to just continue, and we're not going to be able to go back. I don't really see how we're going to be able to tell, you know, patients and members of health plans that, you know what, we know this is more convenient. We know, you know, this allowed you to not have to drive in and sit in a waiting room, but we're going to go back, you know, to 2019 now that it's 2024, and, you know, sorry, I think people are going to switch plans or go to the sort of direct to consumer route, and then fragment their relationships with providers. So, you know, Farah, help us make sure that.
No, I hear you. That's on our minds as well. I mean, obviously during the pandemic, we're not changing anything, but, you know, it's really the post-COVID world. What is it going to be like?
But I think the tech savvy millennials are also going to drive this. You know, healthcare is expensive in the way that we've been delivering it now. It's cumbersome. Technology is here. They know how to use it. They want to use it. They think it should lower cost. It should improve access. And, you know, again, because the insurance-based model, you know, to your point, you know, needs some work in terms of cost control and how we're doing things. You know, the millennials are driving this outside the box. Let's take it outside of insurance. Let's use technology. Let's do it differently. And it's growing like gangbusters.
And we're keeping track of that. Absolutely. Innovations in healthcare is certainly on our mind as well.
Thank you all so incredibly much. I suspect we could talk about this for much longer, but I really, really appreciate all of your insight and expertise. This was really fascinating.
Thank you. It's fun.
Thank you. And Dr. Pace, did you want to introduce, or do you want to transition and introduce Dr. Wadden and Dr. Spaniolo for our very last discussion of today's program, our fireside chat? It's time to get cozy.
We're really excited to hear both of your thoughts and kind of pulling together some of the issues that we've discussed today.
Great, thank you so much. Thank you, Dr. Pace. Thanks, that was a great discussion. We had a lot of questions that we couldn't get to, so we're gonna have to add some podcasts to the Connors Center Conversation podcasts, because there's a lot of energy for this topic. So thank you, Dr. Pace. And Dr. Spaniolo, I'll turn it over to you.
Thank you so much.
Thank you.
And thanks, of course, also for to Lydia for moderating this very, very important discussion. So for this last part of our webinar, I'm so pleased to have Dr. Yasmin Wadden joining me in continuing our conversation about telemedicine and the health of women. And Dr. Wadden will provide you a further perspective about this very critical topic, that is the perspective of pharmaceutical companies. So thank you so much, Dr. Wadden, for representing this perspective. So,
excellent. Thank you so much, Vera.
Thank you, Yasmin. So why you don't start by introducing yourself? I mean, you're an OBGYN and you're the senior medical director at the Women Health for Bayer Pharmaceutical, but why don't you tell our audience exactly what you do?
Perfect. Thank you again, Vera. It's honestly my pleasure to be here with you and the other panelists and our audience today. So as you said, I am an OBGYN and I work with Women's Healthcare Medical Affairs Division here at Bayer. And the work that we work on as part of medical affairs here at Bayer is really around initiatives such as educational support and developing materials specifically for women's healthcare providers and their patients. We also are partners and develop partnerships with groups that help to address barriers to access for women. I can give you an example of one that we recently launched, and that is a partnership with Direct Relief. For this partnership, we are working to provide donations of units of contraceptives to clinics that serve the underserved, right? But on top of that, also help to provide multiple grants that will support novel delivery of care models, again, to these clinics and providers that serve the underserved and the uninsured. Because again, as you've heard from the panelists before us, these are in these particular times the communities that struggle with limited access. Both in this crisis, like the one that we're experiencing with COVID, but also outside of it as well.
That is wonderful. Thank you so much for providing this perspective. So let me ask you something that partially you have already told us, but let's get a little bit deeper into this. So why, pharmaceutical companies like yours can be interested in telemedicine? Where do you see, specific opportunity for women and their health needs, but also besides healthcare, think about, for example, the way we do research, the way we conduct clinical trials. Tell us a little bit about that.
Sure. So I think to take a quick step back, an important point to underscore here, Vera, is that we're all part of this access puzzle and landscape, right? The providers we heard speak, previously, Vera from the payer's perspective, we all play an important part in bridging gaps and breaking down barriers that exist in terms of access to healthcare. And I think telemedicine has proven to be crucial in terms of bridging these gaps. And that, again, as I said before, have always existed, but I think have been sort of underscored and highlighted because of the crisis and further realized due to COVID. So it has allowed patients to access their providers, access education about their health and care that they need. And this is, not only vital during this time, but beyond that as well. And hopefully the lessons we learned here can be pulled through post the crisis and post COVID. In terms of the interest in telemedicine, but also in the learnings that we take from this and gather from this, they can certainly be applied in many aspects, also sort of on the corporate or pharmaceutical side, because as you said, we've had to adjust our clinical trials because patients can't be seen in person, right? So how can we start to make adjustments in that space as well to account for some of these gaps? And we're certainly already starting to implement this.
Yeah, no, I think, what you said, it's really true. I think, that really one of the, adding value of telemedicine could be, for example, to address that gender gap that we have seen for so many years, unfortunately, in enrollment in clinical trials. So it can hopefully facilitate, women
Exactly.
part of those, studies. So I want to, go back to something you said, that is about access, and it's about how, we really started using telemedicine to respond, to a crisis, to an health crisis. And, there is something that they call the tyranny of the urgence. That is, when you're, responding to a crisis and to an emergency, you tend to focus on, few specific things and kind of leave everything else, as I'm going to address this, later. But now, as you said, we are opening a new page that is, implementing telemedicine in the future. And you mentioned, together with the other panelists, the importance to look at this implementation with health equalities and access in mind. So my question for you is, do you think we have the tools, we have, the metrics to measure whether we're going in the right direction? And what are the factors, that we should really think about, that we should really make sure we are including and measuring over time to make sure that we are going in the right direction?
Sure. So I think we have to start somewhere, right? And we're doing that now. COVID has provided this platform where we've sort of are starting to understand what a powerful tool telemedicine and telehealth is. And I think, folks outside of the payer and health, sort of integrated delivery networks are starting to understand that as well. You heard Lisa talk about these opportunities where they have patients paying cash and out of pocket for these services. So folks understand what a powerful tool this is. And so, learning from the experiences we're having now, listening to our providers, like the panelists that we just heard from, that are telling us what's working, what's not working, what can be implemented for certain patient populations versus others. And the input and feedback from the patients will really help us understand what works and what doesn't work. And then from there, we start to establish metrics for what good looks like, and hopefully get ourselves to a point to what great looks like and what great is. But I think it's a matter of just being cognizant of what we're going through, taking a look at what's working and what's not working, and then making sure that we implement that moving forward.
Yeah, I agree with you. And as other panelists have said, we need data, we need data, we need data.
Exactly, yeah.
Most important take-home message, from this webinar for all of us and for our audience as well. So I want to, get a little bit deeper into, something that you mentioned, and when we were talking again about, making sure that, everybody would have access, to this, new, I would say, dimension to provide, care, but also to conduct research and to bring, new therapeutics, to bring innovation, in the larger field of, of medicine. So, one of the things that we see, when we talk, for example, about therapeutics or about diagnostic tools, is that there are, gender differences, for example, in, compliance to a specific therapy, in the access and utilization to that. So do you expect we're gonna see gender differences in how much, for example, women and men would utilize, telemedicine and other, digital health tools?
Sure. So, COVID and the health concerns that are associated with it have really, again, as I said before, shown a spotlight on the gaps that exist in access and healthcare disparity. Again, these have always been there in the background, but I think this is an opportunity where we've been able to sort of realize that a bit further. And this has really served us an opportunity to reconsider the issue of health equality and social determinants of health, and really take a look at the way we deliver care, which includes, again, the use of telemedicine, as you said. There are many factors that impact the ability of a person to access care: transportation, childcare. One of the other panelists brought that up. Healthcare coverage, and really the types of services that we're seeking. And so I think that needs to be taken into consideration in terms of gender equality and equity. Oftentimes, again, women will be the ones bringing their children with them to the clinics, or that will be caring for children in the background. And so we need to take that into consideration when we think about these platforms for care. Oftentimes women will be the ones who will deprioritize their health in an effort to sort of serve up the opportunity for their families to have that care. So just being cognizant of that, understanding it, and trying to implement ways in the way we deliver care, even through telemedicine, I think will get us a long way in terms of bridging that gap.
Yeah, I think you did a very good point about when you said that we as women always wear multiple hats, and that sometimes push us to put our needs at the very bottom of the list. And surely telemedicine could be a way to reduce that gap that sometimes is there, that unmet need, and that tendency that sometimes we have in postponing our needs. And to conclude our chat, I have a last question that is a little bit more maybe personal. As physicians, we talk a lot about how the therapeutic environment, the therapeutic context really shape the efficacy of the therapy, the treatment that we offer to our patient. What do you think from now the perspective of a physician should be the most important thing that we need to think about when we approach patients in this virtual space to make them make the best out of it?
I think for me it's all about, I guess I'll use a buzzword. The first is patient centricity, but what I mean specifically about that is understanding that the patient sitting before you and the patient that we look to serve and break down barriers and increase access for, they are more than a two-dimensional person, right? Coming to you with that one specific request or seeking care for that one specific sort of like complaint, right? These folks are three-dimensional, right? Their lives are three-dimensional, and so that there's so much that needs to be taken into consideration beyond just that telehealth visit. I think the really for me in terms of seeing patients, the value in seeing folks in person is that there's more of an opportunity to pick up on body language, or maybe like facial expressions, or what have you, and that for me helped me to understand and realize again that there are folks are three-dimensional, their lives are three-dimensional, and then there's so much that goes into who they are, and so much more that's being presented to you than what's at the surface or what first meets the eye. And so I think the more we understand that, become cognizant of it, and take that into consideration when we're seeing these patients, at least two-dimensionally, that I think just helps to bring a whole nother level of just greatness, as I said before, to the interactions for telemedicine.
Yeah, I couldn't not agree more than that. I see that Renee is on, so that means unfortunately our time is over. As always, it's a pleasure talking with you.
I actually have one question for both of you. We've got like a minute or two here, and this question came in just as our last question of today's event. Can you talk about clinical trials during the pandemic? On hold / ongoing recruiting, our visits moving to virtual?
Sure. So yes, clinical trials during the pandemic are actually ongoing, and we've implemented a lot of the tools that are being used in healthcare in that space as well. As I mentioned before, telemedicine and virtual visits are a huge tool and resource that's being implemented, both sort of through Zoom or Teams meetings, but also over the phone as well. So because we want to ensure that we minimize any sort of like gap in the study, obviously, but also because we see the value in ensuring these clinical trials to fruition, because at the end of the day, what will happen is the hope is that we come out with a new therapy to meet the needs of our patients. So that's a long way of saying clinical trials are still ongoing, and we are utilizing some of the tools we discussed here today to make sure that happens.
Thank you, Dr. Watt, and thank you, Dr. Spagnuolo. This was a great closing discussion. Thank you to everyone. While we have a few minutes left here, I'm going to turn it over to Dr. Jaffe, who's going to provide some closing comments. And actually, while we're doing that, why don't we actually get everybody back on the screen so that we can see you and say thank you, so that everybody can see you. It'll be like a big Brady Bunch. All right, I see the cameras coming back on. Thank you, everyone. Great. Okay. Thank you. And Dr. Jaffe, over to you.
Yeah, thank you, Renee. It's so great to see everybody. I know Dr. Carusi sent us a message saying that she had a patient emergency, an in-person visit patient emergency that she needed to attend to. So unfortunately, she needed to step away. But I'm just so grateful to all of you, the wisdom, the conversation. The attendees have brought up some really important questions that I think has provoked a lot of thought for me and for us, because there's so much more we need to do. Obviously, we're responding quickly to a rapid change, which is in of itself a huge challenge. But now we need to understand it, study it, and be very intentional so that in the post-COVID world, we get the right balance and do the right thing. And I think the other sort of message and theme that has come out is the patient voice matters, of course, just hugely, the patient-centric. We are all people living these complex lives, and our system needs to keep that in focus. And we have tremendous opportunity for innovation. I mean, we're at the cusp of just fabulous sort of, digital innovation and ability to capture information as we provide care and as we conduct clinical research to advance care, so that we don't depend on these periodic snapshots, that we capture information over time. And I want to just say that, our Connors Center focus includes our major priority that Dr. Spagnuolo is leading, which is our First in Women Precision Medicine platform. And that is play on the term first in man or first in human, to make sure that as new treatments get developed and utilized in the healthcare world, that we make sure that treatments that are used by men and women have sufficient information in women, have sufficient safety information and efficacy information in women. And also utilization and uptake is included, and that applies to all diseases that affect women exclusively, predominantly, and differentially. So, here we are, we're at this really rich juncture where we can take in all these perspectives, and we need to keep up this conversation. You all are in such important roles, play such important roles, and I'm delighted that we have such partnership across all these various perspectives, and delighted to have such important contributions from our audience. So thank you everybody for attending, and thank you for your keep up the good work. We need it. So
thank you everyone. Thanks for joining us today. Thanks for spending some of your Friday with us, and it's been terrific, and we hope you have a good weekend, and we hope to see you all soon.
Thank you.
Bye-bye.
Take care.
Thank you.